evening.
Hi, Dr. Revati. Namaskar.
Ma'am,
Happy
ma'am, good
Diwali.
evening. Ma'am,
Good
ma'am,
evening, ma'am.
good evening.
Turkey
Congratulations,
return.
congratulations.
Thank you,
successfully
thank you.
enrolled the private hospital. Entering the private hospital school first.
Mama. Turkey
Why
return.
congratulations? What is the occasion for congratulations? Sampath?
We have started the school program. We met the director of private schools and today we got the permission. We are going to
Very
do
nice.
counseling
Very nice.
for all private
Congratulations.
schools from
Congratulations.
TNFOG and then government schools.
We are planning to do both in government as well as private schools and cover all the students in Tamil Nadu.
So nice. So nice.
Adolescent girls, 6th to 10th standard.
Very nice.
Okay.
Okay. Radhika, we
Can we
can
start, ma'am?
Yeah.
Okay.
Sahiti,
Yes, ma'am.
We can start.
starting you can start. I will welcome and I will hand over to Radhika.
Okay, ma'am. Good evening, esteemed faculties and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on infertility, organized by TNFOG. So let me introduce the MOC of today's webinar, Dr. T. Radhika Gauri, ma'am. Ma'am is specialist
Sahiti, 1 minute.
consultant in OB.
Sahiti, I will introduce.
Okay, ma'am. Okay.
Okay. You have started the recording now?
Yes, ma'am.
Yes. Good evening to all. I welcome all the delegates and the faculties for our TNFOG Marathon CME. Every month we conduct this on the second Wednesday. The term marathon is mainly because every month we have 3 sessions. 1 Yuva session, 2 Yuva will be talking and it will be judged by the same judges every month. And finally in the annual conference, best speaker will be awarded the prize. And the second session is by the seniors and third is the panel on case scenarios of the infertility. Today we have the topics of infertility, so it is called as Marathon CME. Today's MOC is Dr. Radhika Gauri. Radhika Gauri is Tanjavur alumni and he is MRCOG in UK, 10 years experience as registrar and member of Oxy, RCOJ, IMA, and her field of interest is high risk. Dr. Radhika, you can take over.
Thank you, ma'am. Thank you so much, ma'am, Sampath ma'am and Revati ma'am for this opportunity. Welcome all the esteemed delegates and speakers for this session of infertility. And on the 10th November of 2023, let us start this program with Tamil Thai Valthu.
By Dr. Revati Madam.
Yes. It's okay. Good evening, friends. It's indeed my great pleasure to welcome you all to this very, very important CME. And, this continuing medical education monthly CME is going on for the past 2 years. And it's because of the great initiation by our beloved Secretary, Dr. Sampath Kumari. And I welcome our chief guest, Dr. Kamala Selvaraj, and Asha Bakshi, Dr. Asha Bakshi, and also our evergreen judges, Dr. Vijay Lakshmi Kandasamy and Niti Sarma. They are really doing a great job continuously. And I welcome our speakers also, the Yuva speakers, as well as the panel moderators. The Yuva speakers from Coimbatore and Nivedita Kamaraj from Akash Fertility Center. And the scientific session, we are going to have an interesting talk on Surrogacy Act by our MC Patel sir. And at the end, we are having an interesting panel discussion on interesting cases like in which our panelist experts in infertility practice are going to participate, which is going to be moderated by Dr. Ramani Devi and Chitra. I welcome all of them, and I welcome all our delegates, also the participants who are definitely good, because Humpty number of times we are hearing a lot about infertility management, but still we do not get success in every case. So in each and every case, there will be a hitch. And I'm sure by the end of this session, you get a lot of take-home messages, which you can make use of in your private practice also. Thank you very much and welcome you once again.
Thank you, ma'am.
Radhika, you invite Jairani. Due to some unavoidable reason, chief guest is not participating. So, as I told, Dr. Jairani can introduce Dr.
Good evening, everyone.
Sahiti, can you please display Madam's Jairani ma'am's CV? Sahiti?
Yes, ma'am.
Jairani ma'am. Yes. Welcome, Dr. Jairani ma'am. She is the Senior Consultant of Reproductive Medicine and Director of Akash Fertility Center and Hospital, Chennai, President of OGSI, Treasurer Tapisar, Associate Secretary in World Association for Sexual Health Advisory Association for Sexual Health, and she's been member of ISAR and as a lifetime member of OGSI and ASRM, and member of European Society of Reproduction and Embryology. And she's won lots of medals and awards, and she's been awarded the Women of the Year in 2010, and also Women Achiever Award from Nalam Hospital. And she's also been awarded Best Paper Award for Sexual Dysfunction in PCOS infertile women. And she's very famous in Tamil Nadu as well as all over the country. Welcome, Jairani ma'am, and I request her to introduce Dr. Asha Bakshi ma'am, our chief guest for today's session.
Thank you, Radhika. A very special thanks to my mentor, Dr. Revati madam, and my very good friend Sampath and Ramani madam for giving me this wonderful feeling of a very pleasant feel to introduce my good friend and a very enthusiastic person who is there in infertility practice, who is an infertility committee chairperson, and also who is the vice president of FOXI, Dr. Asha Bakshi from Indore. Madam is the leading consultant in association with the Motherhood Hospital in Indore. She is the present vice president, West Zone FOXI, and she has been the founder chairperson of the Madhya Pradesh IAGE and the Madhya Pradesh ISAR. And she is the member of executive committee of AACC RCOG West Zone. Presently, she is the treasurer of ISAR, and also she is a member of the ICOG Governing Council between 2018 to 21. And she has a credit of doing the first ICSI teaser, micro teaser babies of Madhya Pradesh, and she has been a recipient of Kumud Tamaskar Award FOXI 2008 to 2009, and has received the best paper in the FOXI Journal 2011 and 12, and Padma Shri Dr. S.K. Mukherjee Award in 2021, and has received the Excellence Award Dainak Bhaskar 2021. And she has been so dynamic to organize many conferences. A few among is our past AACOG 2022 Indore, which was so successful. and has organized many conferences like Star Endogen 2019, Icon 2017, and ISA 2016. And she has done so many wonderful CMEs and wonderful congresses when she was an infertility committee chair, and there's been a great pleasure to work with her in that committee. I welcome you, Madam Dr. Asha, for your words of wisdom. Ma'am, unmute, ma'am.
Thank you so much, Jaya, for the kind introduction. And you have been a close friend, and we have been associated since last so many years. And in fact, my first CME in Chennai was when you were the president and you had invited me. So very fond memories with her, and with in Andaman also, the program very well organized by Dr. Sampath Kumari and Jaya was really a hit program, which I always remember and really thoroughly enjoyed. And my regards to Dr. Revati ma'am, who is the president of TNFOG, and I know her since long, and really I respect her a lot. And so nice to see so many people here today. And I was expecting to see Dr. Kamla Salvaraj also, who is a very well-known figure in the field of infertility. And today you've got such good Yuva orators who are going to speak on AMH and semen analysis. And I think these things are very, very important. Why? Because people think infertility means everything should go to infertility specialists, but that is not so. I think there are so many things which can be solved just at primary level, just by taking a good history, just assessing the good ovarian reserve, the tubal status, and semen analysis. And so many finer points are there, which through your good counseling, through simple treatments, you can treat, and the patient will be so thankful to you. And I think you are the closest to that patient. In infertility center, that patient will get lost, but you are the main person who are close to the patient. And I think it's very important to first try naturally as much as possible. Of course, if it is a case where there is reduced ovarian reserve or so, then you have to fast track the treatment. But otherwise, naturally is always the best. So try to do that at your primary level. Medical legal problems. So you may not be doing the surrogacy, but you may be a part somewhere, and at least you should have general knowledge. So I'm sure through Dr. MC Patel, we are going to have lots of good take-home messages. So, and my one appeal to all of you is that whenever you see a patient, just think about her ovarian reserve. And maybe she is postpartum, maybe she is post-abortal, and people think that I've conceived, so there won't be any problem in future. But there are problems, and we all are facing so much of reduced ovarian reserve that it is very important that we get sensitized towards it, and at least we can advise the patient to plan the pregnancy in time, so that she doesn't end up in IVF. So that, I mean to say, a pre-conception counseling and a pro-fertility counseling and the fertility assessment should be a key point for every gynecologist, and we should really think, get sensitized towards it. So it is so nice to be here and to see all these pleasant faces, enthusiastic faces. And I always feel that the South is really, whenever you see whenever I see all of you, I have a little bit of that religious feeling towards people who are very close to their culture. And that's what makes me praise you people so much. So thank you very much. And it has been a great pleasure. And anytime in future, I'm available at your service. Thank you. And wishing you a very, very happy Diwali.
Thank you, Asha. Thank you. Wish you the same.
Yes, wish you the happy Diwali, Asha. Thank you.
Thank you.
Yes.
Thank you, Asha ma'am. That was a wonderful message. The next session is a Yuva session. And I welcome Dr. Nidhi Sharma ma'am, who is the professor at Savita Medical College at Savita, and she is a professor of Obs and Gynae at Savita University, MBBS and MS from Banaras Hindu University, Varanasi, India. She is a fellow of Indian College of Obs and Gynae, fellow of Assisted Reproductive Techniques. She's done her diploma in IVF and reproductive medicine from UKSH University. And in Germany.
Thank you, ma'am. I'll introduce the Yuvas, ma'am, now.
All right, ma'am. Welcome. And
yes,
I also invite Dr. Vijayalakshmi Kandasamy, ma'am. They are the judges for this session. Dr. Vijayalakshmi ma'am is a professor of Chettinad Hospital and Research Institute, Kelambakam, Chennai, and she has won special prizes achievements.
Thank you, Dr. Radhika.
Thank you.
Let's go ahead with this session.
Okay.
Thank you so much.
Nidhi ma'am, can you please introduce?
It is my pleasure and honor to introduce Dr. Jayashree Natarajan. She is a fertility specialist and consultant at Apollo Fertility, Karpakam, Chennai. She is a clinical director and fertility consultant at the S.J. Craft Fertility Center, Coimbatore. She is affiliated with the Reproductive Medicine Fellowship from the Craft Hospital. She is a member of POXI, COGS, member at ISAR, member of IFS, member of ASRM, and a member of TAPSR. She has been an invited faculty to various national and international conferences. Her special interest being poor ovarian responders, PCOD, and recurrent implantation failure. Dr. Jayashree Natarajan, we welcome you. Stage is yours.
Thank you so much, madam, for a warm invite.
Yeah, you can show your slides.
Is my slides visible, madam?
Yes, ma'am.
Good evening to one and all. At the outset, I thank TNFOG and Dr. Ramani Devi madam for giving me this opportunity to present on the topic on WHO Semen Analysis 2021, a critical review. Now, this is going to be the outline of my presentation, where we are going to...
Dr. Jayashree, you will be given 12 minutes and 3 minutes question answer by the judges.
Yes.
Okay.
Yes. Thank you. So this is going to be the outline of my presentation, and in the upcoming slides, we will be talking about the evolution of WHO manual, the highlights on the new WHO reference values, implications of this new manual in clinical practice, and what is going to be the future 2030 manual. So we all know that infertility affects around 1 in 8 couple of reproductive age, where male factor contributes around 20 to 30%. Semen analysis has become the cornerstone of male fertility evaluation. Evaluation of the sperm parameters has been done by the standards defined in the laboratory manual by WHO. From the first edition to the current edition, significant advances has been done in semen examination techniques, methods of sperm preparation and cryopreservation, and technologies to improve the quality control and assurance. With regard to the evolution of WHO semen analysis, where are we at present? This all started in 1980 with the first edition, and at present, we are in the 6th edition, which was published in July 2021. And according to that, the semen parameters are as follows, where the sperm concentration is around 16 million per ml, the total sperm number being 39 million per ejaculate, total motility of 42% with a progressive motility of 30%, and vitality of 54% and a morphology of 4%. So with the short historical background, which started in 1980, was the first edition with a few pages in the manual with the description on the semen analysis, sperm cervical mucus interaction. The second edition came in 1987, where the examination was divided into the standard and the optional test, and there was introduction of normal values of semen variables. Following this was the evolution of the third edition in 1992, where research tests were also included along with the standard and optional, and concentration was more on the sperm preparation techniques and quality control. And followed by this in 1999 was the fourth edition, and this was divided into 3 parts, the standard, optional, and research, and more importance was given to the quality control and methods on implementing this quality control. The 5th edition was published in 2010, and this is the most extensive and comprehensive edition of the WHO manual so far, because it provides greater details on the procedures. It included the total sperm per ejaculate as an important parameter. It also described methods to estimate very low sperm count and also errors while reporting no sperms. New morphology plates were introduced, newer procedures for sperms retrieved from testis and epididymis, cryopreservation of sperm, and it also updated methods on quality control and assurance. The reference ranges and limits are based on the samples from fertile men whose partners had a time to pregnancy of less than 12 months. The manual utilized the one-sided 5% as the lower reference limit. Now, though it was an elaborated manual, the criticisms in this 5th edition was that it suggested reference ranges of semen parameters as the mainstay in the evaluation of male fertility. It had inadequacy in representing the general population, where there was a voluntary nature for the inclusion of most of the cohorts, and there was over and under representation of some areas of the world. There was intra and inter laboratory variations where some labs lacked the formal quality assurance and control. Now, moving on to the highlights on the new 6th edition. So this edition was released in 2021, and it took around 3.5 years to formulate this manual, though there was a time lag because of the COVID pandemic. This had a combined data of the previous 5th edition with additional new data, which was collected between 2010 to 2020. Again, this were from fertile men whose partners had a time to pregnancy of 12 months. Therefore, 3,589 fertile men were the subjects in this. The countries which lacked representation in the previous edition from Southern Europe, Asia, and Africa were included in this study, where we can see that the major contribution was from China, around 1,200. The 6th edition aimed at optimizing the semen analysis procedures by giving a detailed step-by-step procedure. Newer sperm tests were introduced, obsolete tests were abandoned, and we also have 2 new chapters on extended examinations, which have the genetic and genomic testing, and advanced examinations, which has tests used in research like the sperm acrosome reaction, functional analysis of transmembrane ion influx, etc. Now, the important deviation from the previous edition was that there was abandonment of the reference values. The 5th centile values are only one way to interpret the results of semen analysis, and use of the 5th centile alone is not sufficient to diagnose male fertility. Now, when we see this table comparing the 5th edition and the 6th edition, in the values, there is, especially the 5th centile, there is no significant difference from each other. But then additional adding of new areas and participants has provided a greater statistical power to the reference ranges reported. Now, moving on to the examination of the sperm parameters, the semen order has been included in this parameter, but the evaluation is subjective and makes standardization of this parameter very complicated. Moving on to the motility, categorization has reverted to fast progressive, slow progressive, non-progressive, and immotile, as it was mentioned in the previous 4th edition. To justify this choice, WHO manual has cited the older paper saying that the rapid motility has a clinical value. Now, this distinction is added to the 6th edition without any recent studies after 2010. Hence, probably this demonstrates its usefulness in andrology and in clinical practice. Moving on to the sperm count, semen dilutions have been simplified. Sperm vitality is done when total sperm motility is below 40%. And with regard to morphology, better quality and multiple micrographs of spermatozoa has been provided. The terms normozoospermia, asthenozoospermia, necrozoospermia, and teratozoospermia are voluntarily removed, as the editors of the manual explain that reference thresholds alone are meaningless and multiple criteria should be applied to establish a diagnosis of male infertility. Under the extended examination, we have DFI, which is a promising biomarker, and different methods to evaluate the DFI has been described in detail. Under the genetic and genomic test, we have the utility of FISH, in which they have described the procedure of FISH and also the involvement of FISH in assessing the chromosomal aberrations. Under the advanced examination, we have the evaluation of seminal oxidative stress, sperm acrosome reaction, functional analysis of transmembrane ion flux and transport in sperm, and methods for the evaluation of chromatin condensation. We all know that oxidative stress affects all sperm functions, resulting in poor fertilization and reproductive outcomes. Determination of the oxidation reduction potential and total antioxidant capacity are mentioned with brief description and a brief description of the procedures. Now, the limitations of these extended and advanced examinations was that indications of this testing and how to apply the results in clinical practice is missing. It provides no threshold, and the manual recommends each lab to develop its own reference. Despite more evidence being published, the manual has not yet fully endorsed oxidative test as a diagnostic tool. Therefore, this important omission of the above said points can lead to inappropriate use of these tests in clinical practice. And again, without some guidance, utility, and how the test will be used to guide the management in infertile couples is unclear. With regard to the sperm preparation and cryopreservation, two main novelties is the magnetic activated cell sorting technique and the sperm vitrification technique. In MAX technique, it is the selection of sperm with potentially undamaged DNA, but this is not described as clinically valuable because the WHO states that Cochrane review has not shown effectiveness in increasing the live birth rate, and this is not approved for human in vivo use in the United States. Now, what has been discarded is that the zona-free hamster oocyte penetration test and the zona pellucida binding test, because there was difficulty in obtaining the test material, there was lack of standardization, high lab variation and cost, and availability of ICSI has eliminated the necessity of these tests. Along with this, the sperm interaction with cervical mucus has also been eliminated because it is no longer being routinely performed as a part of infertility investigation. Now, let's talk about the clinical utility of this manual. Distribution data with the fifth as a lower reference does not have any distinct boundaries between the fertile and infertile men. And the manual describes only one recommended method of assessment of semen parameters. So this simplifies the procedure in the lab and more reliable result for the clinician. In actual clinical practice, clinicians may encounter some degree of confusion with the absence of reference values, and hence they will continue to use the fifth centile values. A feasible solution for this would be to determine an individualized reference threshold or a limit of semen analysis for selected category of patients based on thorough evaluation of their pathology while considering potential sources of variability in these results. Now, moving on to the SWOT analysis of this manual, the strengths being this manual has addressed the imbalanced geographical representation from the previous edition. This has allowed clinicians to interpret the analysis in a dynamic manner. It has updated the laboratory technical guide and has given information on the QC and QA so that there is optimal lab performance. And it has introduced the extended test, and it has acknowledged that the fifth percentile values alone are insufficient to diagnose male infertility. The weaknesses being geographical areas like the South America and Sub-Saharan Africa are underrepresented. We also have to have in mind that India, being the topmost in world population, is not under this population study. So the reference values from this manual has to be used with caution. This lacks reference thresholds and decision intervals to replace the fifth percentile, and it lacks indication, criteria, and cutoff values for semen DFI testing. It considers seminal oxidative stress as a specialized and research test, despite the extensive literature data which has been there. Now, the opportunities from this manual is that the future research can be on globally accepted reference ranges and threshold for management, updated guidelines on advanced sperm tests like semen DFI testing and fluorescent in situ hybridization. It should incorporate epigenetic and seminal OS testing into the clinical practice. The threats being, because of the abundance of clinical technical details, this may diminish interest among the clinicians reading it and those who want to adopt it. There is lack of reference values for the semen parameters. So this can preclude the global utility and increase the chance of continued use of the previous edition. So what can we expect in the future 2030 manual? Larger prospective studies with well-defined population and different geographical location, and semen from fertile patients with a reduced time to pregnancy, at least 4 months, may be worthy of evaluation. Evidence-based reference ranges are pivotal to male fertility regulation and clinical intervention, and urgent and substantial requirement to fund and deliver these is required. Hence, to conclude, earlier editions had much of focus on the prognosis of fertility and infertility. But there's been a shift in the paradigm and is now under the way where semen analysis is a tool for understanding the function and malfunction of the male reproductive organs. Semen analysis is never a prognostic of fertility, as it is a fertility potential of the couple that defines them. Now, this WHO manual functions as an aid and a foundation for human semen examination and processing, but it is not intended to replace actual clinical management of male fertility. Continuous improvement and updating the manual every 8 to 10 years can introduce new and emerging tests for research and clinical validation of significance into practice. Though there are significant advances in understanding of the male reproductive health, the translation from basic science to clinical practice on the management of male infertility is still limited. These are my references. Thank you so much for the opportunity.
Yeah, thank you, Dr. Jayashree. That was a very elaborate and very beautiful presentation. You have covered all the aspects of how it has evolved over the years. I have two questions for you. One is you mentioned about the epigenetics. Can you elaborate on what are those parameters mentioned in semen analysis? Epigenetic parameters.
Basically, the genetic tests are recommended for in this new chapter. It is covered under the advanced examinations and under the extended examinations, and they have recommended this genetic test for patients who have had a history of recurrent pregnancy loss, male with Robertsonian translocation, unexplained infertility, and male who have had a high semen TFI. So for these patients, they are recommending genetic test with the use of fluorescent in situ hybridization in order to see whether there is any genetic damage in the sperm, which is resulting in the failure for reproduction.
Okay. What is difference between genetics and epigenetics?
Epigenetics, I think it's something. I'm sorry, I'm not able to explain that.
Yeah, no, actually, it is just how the environment factors affect the semen parameters. Yeah, that is epigenetic. So genetic parameters are different from epigenetic parameters. So that comes as rosy. Instead of ICSI, we have rosy these days, ROS. Okay, another second question is, like you have told about the acrosome intactness that CAP assays under immunofluorescence. Can you tell the basis of that test? Can you tell the basis of that test? About the acrosome CAP intactness.
Sorry, madam, I didn't hear you.
Yes, sperm CAP, acrosomal intactness assays. Recently, kit is also available for that.
I'm not able to hear you, madam.
Yeah, acrosome head intactness assessment. One of the new methods of assessment in 6th.
I'm really sorry.
Yeah.
Like your voice is breaking and I'm not able to follow
Okay.
it.
Okay, can I... Acrosome head intact assessment test. Okay, Nidhi, she is not able to hear.
Okay, doesn't matter. Ma'am, we'll ask ma'am to ask. Vijay Lakshmi ma'am will ask.
It's a very nice presentation.
Yes,
you were very comprehensive. You were talking about the oxidative stress test also being included in the recent manual. So what are the tests that are to be done as part of that, and what is its clinical implication when it comes to treatment? Can you hear me? Dr. Jayashree, I think she's...
Dr. Jayashree ma'am has got disconnected now.
There is some problem, I think, because Nidhi was talking now, that also she was not able to hear.
Yes.
Oh,
ma'am, I think she has answered my first question. So
yes,
we will go to the next speaker, ma'am.
Yeah, then probably we'll have to move to the next speaker, and if in case she logs in, we can try and
if she joins, Vijay, you ask that question.
Yeah, sure.
Okay.
Now let's move on to our next speaker, Dr. Nivedita. She's a consultant and executive director of Akash Fertility Center and Hospital, who has her FMAS as well as advanced infertility training and diploma DRM at Leeds University. She's had several national and international presentations at various conferences, and one of her publications at the TNFOG was Placenta Accreta and its management strategies. Over to you, Dr. Nivedita. Speak on AMH.
Thank you. everyone from TNFOG and especially ma'am, Dr. Sampath Kumari ma'am, Dr. Revati Janakiraman ma'am, and Dr. Ramani Devi ma'am for giving me this opportunity. Thank you all the judges here for giving me this opportunity. So I will just share my screen.
Open your presentation. First it was seen.
Minimize this window, ma.
Yeah, so I'm only able to, I'm not able to, yeah.
What your mom is telling you. Madam?
Good evening.
Nivedita, screen not seen, Nivedita.
Nivedita, your screen, you have to, no, Zoom only is seen, Nivi. You just close down, share the screen again. Keep your presentation open.
Okay.
You can stop share now. You can stop share.
Yeah, first you
stop
had
sharing.
the sharing done properly. Yeah. Please share again. You open the presentation.
No, but I couldn't. I couldn't see it.
Yeah, now it's we can see yours and put it in the slideshow.
See it at that.
Yes.
Yes.
So today, my topic is role of AMH in infertility. So as we all know, anti-Mullerian hormone is a glycoprotein, which was originally known as a Mullerian inhibiting substance. It appears during puberty, produced by the granulosa cells, the preantral cells and the small antral follicles. It is not expressed by the atretic follicles or the theca cells. And as we know, it reflects or it mirrors the size of the resting primordial follicle pool and thus acts as a useful marker for ovarian reserve. An initial increase in AMH until the early adulthood is noted, after which there is a slow decrease in the concentration of AMH as age increases. And around the menopausal age group, that is 5 years prior to menopausal age, there's a sharp decline or there is an undetectability in AMH levels. It is usually done to forecast the lifespan, a reproductive lifespan, to know the ovarian response to stimulation, to predict any ovarian dysfunction, and also to predict the fertility potential in gonotoxic cancer treatment or ovarian surgery. So AMH is produced by small growing follicles, that is the primary and the preantral follicles in the ovary. And it has two actions where it inhibits FSH-dependent growth and selection of preantral and small antral follicles, and also the initial follicle recruitment. So the intrafollicular concentrations of AMH in normal human antral follicle shows a gradual reduction as the diameter of the follicle increases. So, and there's a sharp decline where after the around 8 mm sized follicles. It's also like it acts as a physiological gatekeeper where it prevents excessive follicle recruitment. The factors that influence AMH concentrations are overweight. So there are studies which say that in women who are overweight and obese, about 65%, they have a 65% chances of low AMH levels compared to thin women. Vitamin D has a role. So does smoking and alcohol, which increases the AMH levels. Polymorphism of the AMH receptors and its receptors, ethnicity, genetic variants across the genome. AMH is unaffected because it is not cycle dependent and it can be measured any day during the cycle. It has a less cycle to cycle variation than FSH, and it's not altered after downregulation with any GnRH agonist. And it has an increase in cases such as PCOS. So it renders easy to measure at any time as opposed to the currently available markers of ovarian aging such as inhibin B, estradiol and FSH, which are all menstrual cycle dependent and constitute relatively late markers of any primordial follicle depletion. So this is a graph which shows that increased ages and there's a decrease in AMH levels. And often the normal level of AMH is around over 1.4 nanograms per ml. A low normal range is between 0.7 to 1.3 nanograms per ml. Low is 0.3 to 0.6, and very low is less than 0.3 nanograms per ml. And in PCOS, which is where it's often high, it's more than 3.5 nanograms per ml. So AMH of less than 1.3 nanograms per ml has a sensitivity of 75.5% and a specificity of 74.8% in predicting poor response, and of almost 88% and a 67% specificity in predicting hyperstimulation as well. So why should we do an ovarian reserve testing for a subfertile couple is so that we can plan and give them a pre-treatment counseling. Like for a general patient who walks in also, like if they want to plan their pregnancy, now we live in a age where 30 years is when they have their first live child. So in case like they want to plan their pregnancy later, doing an AMH level might predict, which can give them an option of when to plan their pregnancy or plan a late pregnancy, as well as like in case they have difficulty in conceiving, the choice of fertility treatments and options can be explored by doing an AMH level. Also, freezing options could be availed in case of low AMH at an early age, and to avoid ovarian hyperstimulation as well. So as we spoke, AMH helps to predict the fecundity and accurate ovarian reserve as well. Increasing age means there's a decrease in AMH level, and low AMH level at any given time, irrespective of the age, predicts a poor response to ART. High AMH level, they're prone for ovarian hyperstimulation syndrome. So AMH in IVF is when it can predict when there's a poor ovarian response, it can lead to a cycle cancellation or a poor pregnancy rate. And in an excessive ovarian response, there's a risk of OHSS, and a high E2 can be detrimental to the outcome. So ovarian reserve testing may allow for a better assessment of the fertility potential of a given woman, but it's not the only thing which predicts or which should be taken into consideration. Even a person with a low AMH level who have not yet started planning a pregnancy should first start trying, and that they can it can lead to a natural conception as well. It's not the only. So AMH is the best currently available measure of ovarian reserve, and it guides us in individualizing dosing for ovarian stimulation, thereby improving the efficiency and safety in IVF. We can give an idea about the expectation on the oocyte yield, the cost for drug regimen, risk of complications can be predicted. There's the chances of disappointment might be lesser when we can predict it earlier. So the dosing in IVF can be planned according to the AMH level. So if the AMH level is lesser, the dosage is more, and when the levels are high, then the dosage is low to get the desired ovarian response. So over other markers, AMH is the earliest marker to change with age, and it has the least inter and intracycle variability. It also can be randomly measured during the cycle. There are no modifications during GnRH agonists, or it has no modification in hypothalamic amenorrhea. It is both convenient and informative compared to basal FSH level. So in multiple studies, a 0.7 nanogram per ml AMH has a good sensitivity and a specificity in identifying 75% of poor responders, and AMH of more than 3.5 nanograms per ml predict hyperresponse or OHSS. So when we look at the AMH values, which are less than 0.4 nanograms per ml, we expect a poor response and the cycle could be cancelled. When we're looking at an AMH level of 0.4 to 1 nanograms, then there can be we should expect a poor response. If the AMH level is 1 to 2, there's a risk of poor response, and short stimulation protocols could be effective. When the AMH level is around 2 to 3.5, the response might be adequate. We can expect adequate response. And when there's a AMH level of 3.5 to 6, there's always a chance of hyperstimulation. And when the levels are more than 6, there's a very high chance of a severe OHSs, which can be expected. So when we have a high AMH of more than 3.5 nanograms per ml, we need to inform about the risk of OHSs, avoid any agonist, GnRH agonist and a low FSH dose, prefer an antagonist cycle, give an agonist trigger, and the blastocyst transfer or a freeze all embryos and transfer later might be preferred. So assessing AMH concentration in anovulatory women may give additional information about the follicular dynamics with ovarian reserve. The magnitude of AMH elevation in PCOS is associated with the extent of the disease. So improved reproductive performance in relation to weight loss and improved ovulatory functions with age. Hence, AMH testing may allow early detection of subclinical disease even in siblings of women diagnosed with PCOS. So other forms of anovulation, women presenting with functional hypothalamic amenorrhea were shown to have normal AMH levels, suggesting a normal size of the cohort of early growing follicles. Initial AMH levels predict chances of recovery of ovarian function following weight gain in even women with anorexia nervosa. So the management of women with cancer and AMH appears to facilitate establishing which chemotherapeutic agents are particularly toxic to the ovaries. Therefore, during the chemotherapy with some recovery 3 to 6 months thereafter, pre-treatment AMH levels determine the rate of post-therapy ovarian recovery. So acute changes in the ovarian reserve during and after chemotherapy can be done. So predicting menopause. Prediction of menopause by assessing AMH at a relatively young age may enable screening and prevention programs with reference to osteoporosis, breast cancer, cognition, Alzheimer's, and CVS diseases. In conclusion, AMH alone or in combination with antral follicular count is a better indicator for ovarian reserve rather than any other hormonal or sonographic markers available at present. Thank you.
Thank you, Dr. Nivedita. That is a very nice presentation. You have covered all the aspects. My question for you, what is Fort index?
Yes, ma'am. Fort index is when we take the AMH levels and the antral follicular count, and then we calculate it, and then depending on that, we determine whether the person has a poor ovarian reserve or a response, their response. So that is better than just calculating AMH, just knowing the AMH level and then predicting their response.
Okay. And how does it correlate with age? AMH levels correlation?
So AMH level starts declining with increase in age. And after the age of 45, then the AMH level is very, very low. So the fertility potential comes down with age.
Covered all the aspects. The physiology of PCOD also you covered. Cancer patients also covered. That is good. Thank you.
Thank you.
Nice presentation, Nivedita.
Thank you, ma'am.
You did say that AMH is cycle independent, so it can be assessed during any time of the cycle. But there are several recent studies that say that there's slight fluctuation or maybe variation. And depending on what part of the cycle we are assessing the AMH, are you aware of that? Part of the cycle is preferred to assess AMH?
It's a conflicting, there are conflicting studies which does say that early, when we do the basal FSH and LH levels like day 2 or day 3, AMH predictability is better compared to doing it anytime during the cycle. But I'm not aware of the depths of how effective it is, or like what is the percentage of significance or anything.
Certain studies have definitely said that doing it during the follicular phase would be better rather than to do it during the luteal phase, because there's a slight reduction which happens during the luteal phase.
Right.
As Nidhi Madam said, you have extensively covered all aspects of AMH.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, madams, Nidhi Madam and Thank you, Vijayalakshmi ma'am. And thank you, speakers. That was wonderful session and spot on, and you kept the time as well. So let's move on to the scientific session. The chairperson, I invite the chairperson, Dr. Vivek Madi sir, who is a consultant and director of RK Malathi Hospital in Chennai, and he's done his MBBS from Madras University in 1992, and he's completed his MD from Manipal University in 96. And 2007 is honorary secretary of IMA North Chennai branch, and 2008 president of AIMS Association. And he's on top of all, he's a lawyer from Karnataka Law University. And I welcome sir.
Thank you. Thank you, ma'am.
And I request you to introduce
Yes.
and invite Dr.
Yes.
Patel sir.
Thank you very much, Professor Sampath Kumari, Professor Revati Janakiraman, and the organizers of TNFOG for asking me to chair this session. Well, surrogacy has been an issue, a social issue. Many movies such as Mimi, Made in India, Yashoda, Avan Aval, Adi have all come out. They have highlighted how surrogacy is a thing for us to make an act about. Since the birth of the first IVF baby, Durga in Kolkata in 1978, surrogacy has become an alternative reproductive technique for infertile couples. In fact, India has become a fertility hub because of surrogacy as such. Foreign nationals used to come to India for their fertility needs. So it prompted an advocate called Jayashree Vad to petition an institution advocate to petition the Supreme Court and bring to attention about the drawbacks and dangers of commercial surrogacy. Following which, surrogacy was outlawed for foreigners in 2015. People worked on this, and in 2019, a regulation bill was first placed on table in the Lok Sabha. And the bill permits altruistic surrogacy but outlaws commercial surrogacy. On December 25th, 2021, President Ramnath Kovind gave the assent to the bill, which was passed by the Parliament. I go ahead now to ask Professor M.C. Patel to highlight more issues on surrogacy. Give us the details how Surrogacy Act as such has made a change in the way we practice medicine. Professor M.C. Patel, as you know, is a pioneer in the field of medical legal, and he has been the vice president of FOXI 2018. He has brought out a lot of changes in our organization. He's been organizing secretary in AICOG 2017. He has been chairperson Ethics and Medical Legal Committee. He's been honorary secretary of state organizations in Gujarat. He has been national president of National Medicos Organization 2016-18. All of us have heard about him. He is a person with vast knowledge in the medical legal field, brought about a lot of changes, and he will highlight the important facts of Surrogacy Act, how it is making a change in the way we practice surrogacy. Thank you, sir. Over to you.
Thank you, Dr. Vivek, for kind words. Let me share my screen first. Is it seen?
Yes, sir.
Yes, it is full screen.
Yes, sir.
Yes. So, straightway to the subject, very nicely narrated by you that surrogacy as such, now it is commercial surrogacy is totally banned. Foreign surrogacy is also totally banned. Otherwise, India was going to be hub for surrogacy also. Not only for ART, but for surrogacy also. India was going to be capital of surrogacy. But now it is due to this Surrogacy Act. There is some break about this. So let us see. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And before I go to the subject, this is my humble appeal to endorse my candidature for post of President FOXI. election year 2024. Respected seniors and dear colleagues, serving proxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of proxy president year 2026, election year 2024. Consistently working for proxy and trying to visit even a smaller society and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना. So, please endorse my candidature for post of President Foxy election year 2024. And Surrogacy Act we are going to discuss today. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Sampath Kumari in particular for inviting me to share my views about the subject. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because ignorance of law is no excuse. Because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. And medico-legal litigations are increasing in number constantly and steadily. And unluckily, we gynecologists rank first as far as medico-legal consequences are concerned. And any new establishment has its own problem, mainly legal and ethical implications too. And same way in ART clinic or surrogacy clinic or ART bank and etc. As far as ART Act is concerned, enacted in 2022, 25th January, and same way Surrogacy Regulation Act was also enacted on 25th January 2022, and all surrogacy rules which were enacted on 11th of July 2022 and noted in government gazette. So what is Surrogacy Act? Actually, it simply defines an act to constitute National ART and Surrogacy Board, State ART and Surrogacy Board, and appointment of appropriate authorities for regulation of practice and process of surrogacy and for matters connected therewith or incidental thereto. So before Surrogacy Act or before ART Act, there was no regulation as far as this practice is concerned. There was no protocol defined and there was no guideline also how to practice. There was no governing body. ICMR was there, but it has no statutory power. So with this act, when enacted in Lok Sabha and passes in government gazette, now ART practice and surrogacy practice adds its regulation. So first part is very important, and that is registration of center. So no center can function without registration. So surrogacy clinic cannot undertake surrogacy related procedure unless it is registered. So sorry. It is very much mandatory that centers should be registered as far as surrogacy practice is concerned. And for registration, application to appropriate authority with requisite documents, and there would be inspection by team of appropriate authority. And if everything is fine in order as far as equipments, as far as expert person who are going to work there in that very center, then they may consider application, and you have to advise to go for fees. As far as surrogacy clinic is concerned, fees rupees 2 lakhs. And once you have submitted all this and you have paid up the fees, then appropriate authority will grant certificate of registration, and appropriate authority is under obligation that he will have to grant or reject application within 90 days of application done by party. As far as rejection is concerned, appropriate authority may reject application for registration with reason given in writing. But before they reject, opportunity of being heard should be given to the party is one more requisite as far as rejection part is concerned. If registration is granted, then it is valid for 3 years from date of registration. And once it is registered, then certificate of registration is to be displayed at conspicuous place of business. So here word conspicuous place is used. So it simply means where maximum visitors of the hospital can have a look. So waiting area is the area or place where maximum number of visitors may have a look. So certificate of registration should be displayed in waiting room. As far as renewal is concerned, once registration is done, after 3 years it will expire. So before it gets expired, for a renewal, again same procedure one will have to do. An application to appropriate authority in prescribed form with prescribed fee, and registration granted may be renewed for further period of 3 years if it is found in order. No application for renewal also shall be rejected without giving opportunity of being heard to the applicant. So these are the procedure as far as registration of center is concerned, renewal of registration is concerned. Appropriate authority has all the power to suspend or cancel registration for some valid reason. But before that, they will issue a show cause notice, and opportunity of being heard will be given to surrogacy clinic why your registration should not be suspended or cancelled. And suspension or cancellation of registration will be done. An appropriate authority will inform state appropriate authority, and state appropriate authority inform central appropriate authority, and suspension will be considered valid. But if it is in public interest, then all these procedure to issue notice or opportunity of being heard to be given may be surpassed, and appropriate authority straightway suspend or cancel registration. But for that, reason in writing should be recorded, and it should be given in writing why registration of center is suspended or cancelled. If it is rejected or if it is cancelled or suspended, then there is a provision of appeal also. So within 30 days of action taken by appropriate authority, one can go for appeal. And as far as appeal is concerned, if party is aggrieved due to order by appropriate authority for rejection of application, suspension of registration, or cancellation of registration, and they may go for appeal. So where to go for appeal? If this order is from appropriate authority from respective state, then to state government. And if it is a case of union territory, then appeal should be preferred against against appropriate authority before central government. So these are the provisions for appeal also. Section 17 is a constitution of National ART and Surrogacy Board. There will be 3-tier system as far as regulation of surrogacy practice is concerned, and higher board is National Board, and it will be constituted under Section 17. Same way under Section 26, Constitution of State ART and Surrogacy Board. So State Board will work under guidance of National Board. And appointment of appropriate authority, if it is a question of state, then in each district, one or more appropriate authority can be appointed. If it is a union territory, then central government will appoint this appropriate authority. So this is 3-tier system as far as regulation of surrogacy practice is concerned. So, why this surrogacy act was needed and it is enacted? Which are the purposes, permitted purposes as far as surrogacy is concerned? In which condition surrogacy can be considered? For intending couple who suffer from proven infertility, if any intending couple having proven infertility, then in some given situation, they may opt option of surrogacy. But rightly said by Dr. Vivek, now it is altruistic surrogacy only is allowed and commercial surrogacy is totally banned as far as the surrogacy practice is concerned. Not for producing children for sale, prostitution or other form of exploitation. It is one more condition as far as surrogacy practice is concerned. So it is very clear as far as surrogacy practice is concerned. So what is commercial surrogacy, which is prohibited now, and altruistic surrogacy is allowed? So when original bill, which was introduced in 2016, it was defined as a surrogacy or its related procedure for monetary benefit or reward in cash or kind exceeding the basic medical expenses and insurance coverage is considered as a commercial surrogacy. But now with this amendment, this definition is somewhat extended. So commercialization of surrogacy services or procedure or its component services or component procedures, including selling or buying of human embryo or trading in sale or purchase of human embryo or gametes, or selling or buying or trading services of surrogate motherhood by way of giving payment, reward, benefit, fees, remuneration, or monetary incentive in cash or kind to surrogate mother or to her dependent or to her representative. So it is very extensive definition as far as commercial surrogacy is concerned. But there are two exceptions where this commercial activity is allowed. One is medical expenses related to procedure and during pregnancy or after delivery. If any complications happens, then all the expense incurred to surrogate mother will be paid by a commissioning couple. So one more, it is exception. And one more part is insurance. Under this Surrogacy Act, insurance of surrogate mother is very much mandatory, and that very expense will be by a commissioning couple. As far as altruistic consent is now allowed, by that bill of 2016, it was defined like this. Altruistic surrogacy involves no monetary compensation to the surrogate mother other than medical expenses and insurance coverage during pregnancy. But now with this act, which is passed in government gazette now, it is defined as surrogacy in which no charges, expenses, fees, remuneration, or monetary incentive of whatever nature, except medical expenses and such other prescribed expenses incurred on surrogate mother and insurance coverage for surrogate mother are given to surrogate mother or her dependent or her representative. So altruistic surrogacy is defined by this very act. So under this act, who is intending couple? It is also very specifically defined. Under section 2, subsection R, intending couple means a couple who have a medical indication necessitating gestational surrogacy and who intend to become parents through surrogacy are intending couple. And under section 2, subsection S, intending woman means Indian woman who is a widow or divorcee between age of 35 to 45 years and who intends to avail surrogacy. So surrogacy is available with single woman also, but condition is she should be ever married. Of course, at the time of attending surrogacy, she could be widow, she could be divorcee, fine. But she should be ever married, and age should be between 35 to 45. So intending couple and intending woman can avail services of surrogacy in some given situation. But for that, certificate of essentiality is very much required. So what is certificate of essentiality? It will be issued by appropriate authority of that very jurisdiction of center where a center is working for surrogacy practice. So as far as certificate of essentiality is concerned, intending couple should be in a possession of certificate of essentiality issued by appropriate authority after satisfying itself for the reason to be recorded in writing. So appropriate authority, when intending couple approaches appropriate authority, he will inspect all the records related to that intending couple, and he will do all the recording in writing, and then only if it is eligible, he will issue certificate of essentiality. So certificate of medical indication in favor of either or both members of intending couple or intending woman necessitating gestational surrogacy from district medical board. So when there is an indication, medical indication, that this couple or that intending woman is in need of surrogacy, it will be given by district medical board and ultimately appropriate authority. So what is district medical board? District medical board is working under chairmanship of CMO, because it differs from state to state. In some state it is called CMO, that is Chief Medical Officer. In some state it is called Chief District Medical Officer or Chief Civil Surgeon or Joint Director of Health Services of the district. So whosoever officer appointed as appropriate authority in that respective district will be chairperson of that very district medical board as far as certificate of essentiality is to be considered. He may invite 2 more persons in board, chief gynecologist and chief pediatrician, to come to conclusion as far as certificate of essentiality is concerned. But here one gray area is there. There is no time limit given to appropriate authority that once he receives any application for certificate of essentiality, he will have under obligation to give certificate either yes or no. He may reject also, but there is no time limit defined. So it is a gray area as far as this act is concerned. And due to heavy workload, because CMO or CDMO or deputy director or whosoever joint director, they are studied with some other works also. So they are not solely for issue certificate of essentiality only. So due to workload, they cannot issue certificate in time, could be problem as far as certificate of essentiality is concerned. There is no provision of deemed certification also, because in PCPNDT Act, as far as renewal part is concerned, if appropriate authority doesn't respond within 90 days, that center is deemed renewed. So in this procedure of certificate of essentiality, there is no provision of deemed certificate. So one will have to wait till response from appropriate authority. There is also one more gray area. There is no provision or there is no mention about appeal. If appropriate authority is not giving a certificate in time, or if they have refused to give certificate, then can that decision be challenged in other authority? It is also not clear in this act. One more requisite as far as certificate of essentiality is concerned, intending couple will have to approach magistrate of first class magistrate, that is judicial magistrate first class, to have an affidavit about parentage and custody of child. So they will give affidavit like this: after birth of child, irrespective of outcome of baby, they will take custody of that very baby, and the intending couple will have to give this type of affidavit before Honorable Judicial Magistrate First Class. One more area as far as insurance coverage is concerned, it is very much mandatory to take insurance for surrogate mother for 36 months, and all the expense will be from intending couple, and it should be by recognized institution as far as insurance part is concerned, and through recognized agent who are recognized by Insurance Regulatory Department Authority, that is IRDA. So it should be a registered insurance company. So all these documents about parentage and insurance, they will have to submit to the appropriate authority, and then only appropriate authority will issue certificate of essentiality. One more certificate required is certificate of eligibility. And as far as eligibility is concerned, eligibility on part of surrogate and eligibility on part of intending couple or intending woman. So as far as eligibility on part of surrogate is concerned, so she should be, just I mentioned prior also, she should be ever married woman, having child of her own, and age should be between 25 to 35 years at the day of implantation. So when you transfer embryo, at that very time, she should not be more than 35 years of age. Intending couple or intending woman shall approach appropriate authority with a willing woman who agreed to act as a surrogate mother. So all the party involved or to be involved in surrogate process, they will have to approach appropriate authority for this certificate of eligibility is concerned. No woman shall act as a surrogate mother by providing her own gamete. So now with amendment, it is clear that gametes, sperm and ovum, should be from intending couple only. So as far as surrogacy program is concerned, ovum donation or sperm donation is not allowed with amendment which came very recently. So in March 2023, this notification came. So now intending couple must use their own gametes for surrogacy purpose. One more area, no woman shall act as a surrogate mother more than once in her lifetime. So it is very clear she can give services as a surrogate mother only once in her lifetime. But as far as attempt is concerned, she can have 3 attempts from that very intending couple. If, say for example, all 3 attempts fail, can that very surrogate mother give surrogate services to other intending couple? Yes, she can give. But once she gets pregnancy, once she delivers baby, then she cannot go for surrogacy services again. So she can be surrogate mother only once in her life. Certificate of medical and psychological fitness for surrogacy by registered medical practitioner is one more requisite. So registered medical practitioner will certify that person who is going to offer her surrogate services is medically and psychologically fit. Registered medical practitioner can have opinion from psychiatrist also, but certificate should be there. So all this document, once received by appropriate authority, then only appropriate authority will issue certificate of eligibility to surrogate mother. As far as eligibility of intending couple is concerned, again, in this situation, intending couple married or in single ever married, and between age of 23 to 50 for female and between 26 to 55 years in case of male. So it is clear 5 years from the age of majority, because in female it is 18, so 23, in male it is 21, so 26. So before 23 in female, before 26 in male, they cannot avail services as far as surrogacy part is concerned. But again here one more area. Many a times it is a proven infertility due to absence of uterus or congenital malformation of uterus, and they are good subject as far as surrogacy part is concerned. But even then, if they have not attained age of 23 or 26 respectively, they cannot avail services of surrogacy. This is one more area as far as the surrogacy part is concerned. As far as single woman is concerned, who want to opt surrogacy must be between 35 to 45 years of age and must either be married, divorced, or widowed. And if they have one surviving child from a previous marriage or relationship, they are not allowed to opt for surrogacy. So for single woman, it is very much clear. As far as one more area, intending couple have not had any surviving child, biologically or through adoption or through surrogacy earlier. So if they have no child, surviving child, then only they can be entitled for surrogacy program. But there are exceptions for this provision also. If child is having mentally or physically, the child is challenged or suffers from life-threatening disorder or fetal illness with no permanent cure and approved by appropriate authority with due medical certificate from district medical board, then this couple can be given certificate of eligibility. Such other condition may be decided as per regulation by time whenever there is circular from government. One more area, surrogate services can only be available to intending couple with Indian citizen. Dual citizenship is allowed, either husband is Indian origin or wife is of Indian origin, but there should be some Indian citizenship there. One more area, OCI, that is overseas citizen of India, can also avail, and PIO, that is person from Indian origin but residing in foreign country, then they can also avail services as far as surrogacy is concerned. But one more area is consent. So all the party involved in surrogacy program, they should give consent. So no surrogacy clinic shall perform any treatment or any procedure of ART for surrogacy without written informed consent of all the parties seeking ART to all possible stages of such treatment or procedure, including freezing of human embryo. So as far as surrogacy program is concerned, all the party involved should sign consent document. So, and at the time of taking consent, because consent is not mere piece of paper. In one famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your communication, of your counseling. So whatever you communicate, whatever you counsel to the patient, all the importance points should be mentioned in consent paper, and then patient has to sign. So as far as this surrogacy program is concerned, in consent paper, you are under obligation to explain all known side effects or after effects of such procedure to surrogate mother consent. So about all the procedure which surrogate mother is going to pass, and during delivery, during pregnancy and after delivery, all the probable side effects and after effects should be explained to the person who is going to be go for surrogate program. Obtain in a prescribed form written informed consent of surrogate mother to undergo such procedures in language she understands. So it should be in a vernacular language. It is very clear as far as this consent part is concerned. One more provision is withdrawal of consent. Both the party, intending couple as well as surrogate, both are having power to withdraw their consent before stage of transfer of embryo. So before that, they can withdraw their consent. But as far as surrogate mother is concerned, if she withdraws consent, then she will have to give in writing to intending couple as far as this withdrawal is concerned. One more area, prohibition to abandon child born through surrogacy. Under Section 7, it is very clear in Surrogacy Act that intending couple or intending woman shall not abandon child born out of surrogacy procedure, whether within India or outside, for any reason whatsoever, including but not restricted to. Say, for example, if it is genetic defect, birth defect, or other medical condition to baby, or defects developing subsequently, or due to ground of sex of child, or conception of more than one baby. So if, say for example, if it is a twin delivery or multiple delivery, they cannot refuse on the ground of multiple delivery also. So these are the conditions in which intending couple or intending woman cannot refuse to take custody of baby. Right of surrogate child. So right of child who is born through surrogacy program, it is as good as child born as a natural wedlock. So child born out of surrogacy procedure shall be deemed to be biological child of intending couple or intending woman, and said child shall be entitled to all the rights and privileges available to natural child under any law for time being in force. So child is very much legitimate in eye of law as far as child born through surrogacy program. Number of oocytes or human embryo to be implanted, not more than 2. So with this surrogacy program, you cannot go with more than 2 embryo as far as transfer is concerned. Prohibition of abortion. So there is also one provision as far as Section 10 is concerned. No person, organization, surrogacy clinic, laboratory, or clinical establishment of any kind shall force surrogate mother to abort at any stage of surrogacy except in such condition as may be prescribed. Under MTP Act, there are provisions or indications given for termination of pregnancy. So without those indications, nobody can force surrogate mother to go for termination of pregnancy. Sorry. Prohibition of commercial surrogacy, exploitation of surrogate mother, and children born through surrogacy. There is also provision under Section 38. And in that very section, it is very specifically mentioned, no person, organization, surrogate clinic or laboratory or clinical establishment of any kind shall undertake commercial surrogacy, provide commercial surrogacy, or use individual brokers or intermediates or commercial advertisement for commercial surrogacy, or abandon or disown or exploit surrogate mother or child or children born through surrogacy, exploit or cause to be exploited surrogate mother or child born through surrogacy, sell human embryo or gamete for the purpose of surrogacy, run an agency, racket, organization for selling, purchasing, or trading in human embryos or gametes for purpose of surrogacy, or import or shall help in getting imported human embryo or human gametes for surrogacy program, or conduct sex selection. So these are the provisions strictly prohibited, and for that there is a provision of 10 years of imprisonment and fine of rupees 10 lakhs are provision as far as contravention of this act is concerned. As far as punishment for contravention of provision of act, 5 years of imprisonment with fine, which may extend up to 10 lakhs of rupees, and it is for first instance. But if it is repeated, then appropriate authority may write to state medical council of respective state to take necessary action, including suspension of medical registration for a period of 5 years. And one more provision, if there is no specification of punishment for specific offense, then punishment for not following altruistic surrogacy, there is also provision of imprisonment of 5 years and fine of rupees 5 lakhs rupees for first offense, and then 10 years of imprisonment and fine of rupees 10 lakhs for second instances, and penalty for contravention of provisions of Act rules for which no specific punishment is provided. Then there is a provision of imprisonment of 3 years and fine of rupees 5 lakhs is a provision in this. And if this contravention is continued, then there is one more provision that 10,000 rupees for every day will be the fine during which such contravention continues after conviction for first such contravention. So it is very clear as far as punishment part is concerned. Presumption in case of surrogacy. So if surrogate mother is not passed through all this certificate of essentiality, eligibility, and she is not properly selected, then it will be presumed by law under section 42 that she was compelled to go for surrogate by her family members or by intending couple, unless contrary is proved by intending couple or family of that surrogate mother. So it will be presumed that she was compelled to go for surrogacy program. As far as this offenses related to surrogacy programs are concerned, it is cognizable, non-bailable, and non-compoundable. Cognizable means any investigating officer may take cognizance of offense without permission of court and may initiate investigation. It is non-bailable. So bail can only be granted through court, and it is non-compoundable. So once case is filed, result has to come. Case cannot be withdrawn in between. Result could be in favor or against, but it is non-compoundable as far as offenses related to surrogacy is concerned. And this type of cases can only be triable under judicial magistrate first class. And as far as cognizance of offense is concerned, before JMFC, only appropriate authority has power to complain before honorable court. There is one more provision. If any person or social organization has given application to appropriate authority for not less than 15 days, and if there is no communication from appropriate authority, then that very person or social organization may approach JMFC, and if JMFC is satisfied, then JMFC may initiate further investigation. No court inferior to JMFC have power to hear all these offenses. As far as maintenance of records are concerned, all the records related to surrogacy are to be preserved for 25 years, and in case of any legal proceeding, till final disposal of legal proceeding, whichever is later. So all the records, one can have record on paper, on dictaphone, on computer, in any measures you can have record, but they should be preserved for 25 years of age. So to conclude, this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are all the provisions given in Surrogacy Act, but if you do not know, then we may end up into trouble someday. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. So to minimize claims related to surrogacy practice, comply with the provisions of law and have a medical legal opinion since point 1, if at all you are in a little doubt. Because in spite of all these professional and occupational hazard, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient, comply with the provisions of Surrogacy Act, pray Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate to have a phone call to medical legal expert. So all the best. With regards, salute to organizers and particularly to Dr. Sampath for inviting me to share my views about the subject. Thank you very much. Please do not assume. Please ask if any query, any questions, if time and chairpersons permit. Thank you very much.
Thank you, sir. I have 2 questions to ask. Permit me to make. It's just, I know this is a very draconian, stringent law. Well,
Yes.
I would like to ask you, this has come about because there's a social change in our country, and that's why they have brought about this law. You saw I mentioned to you, a lot of movies have come about and things like that. But then there's a social change, and it does not address the LGBT group. What about people are now living partnership is becoming a common norm in today's world. Unmarried people are living together. It doesn't address unmarried women's plight nor a single man's plight. Isn't this sometimes we think this law should have addressed that part?
It is clear, single woman ever married. What ever married you use, either she divorcee or she is judicially separated, then only she can avail. Otherwise, she should be married. Married couple can only get these services.
Yeah, but why not live in partnership?
On to the some NGOs rather, and they approach government. There is a exploitation of surrogate mothers, and then only government had a deep inquiry related to that problem, and then only government has come up with this. And as far as foreign surrogacy is concerned, as you mentioned during your opening remark also, government came with ordinance to ban foreign surrogacy, and then after continuous persuasion on part of NGOs, government was compelled to go for this act, and they had a long discussion in Lok Sabha and Raj Sabha, and they put this act on website also for opinion from medical associations, IMA, FOXI, IFS, ISAR, etc. And then after this act is enacted. So there was so many complaints as far as exploitation of surrogate mothers are concerned, and that is why this act has come.
Now, the second question which I had is, you have mentioned about prohibition of abortion, that nobody can compel a woman surrogate mother to have an abortion.
Yes.
But what if she wants to have an abortion?
So
doesn't she have a right in under MTP Act within 5 minutes?
There should be valid indication. As per MTP Act 1971 is concerned. Even in MTP Act also, it is very clearly mentioned, can one abort or can one avail services of MTP on her will?
Yes.
In one of the cases, Honorable Court has given a very clear verdict that there is no abortion on demand or on wish or willingness. There should be some indication which is given in MTP Act. So if there is any indication given in MTP Act, then surrogate mother can opt way to go for termination. Otherwise, surrogate mother has also no option to go for termination.
Yeah, and also you have mentioned about a notification in March 2023 that came about that no gamete donors can be utilized in.
Yes.
But what about women with congenital absence of uterus, like
congenital absence of uterus? They are very much, because if ovary is there, then from that ovary they can avail ovum and her husband's sperm. Then only they can opt for surrogacy program. Otherwise, donor program, either ovum or sperm, is not allowed as far as surrogacy program is concerned. With this recent amendment came in June 23 only.
Thank you, sir. Anybody else?
Any question?
Very extensively you spoke to us and given us a good idea.
Yes.
Good evening, sir.
Yes, good evening.
Zerani here.
Yes, welcome. Welcome, Jaya.
How are you, sir?
That's fine. Thank you.
So that's an amazing one that you have given about the surrogacy. Definitely, whoever registered with the surrogacy cannot practice surrogacy hereafter with so much of legal litigation.
No. It is not like that. Once your center is registered as a ART clinic, and if you have also registered as a surrogacy clinic, then it has become simple according to me. If any couples come to you, you have to explain all this eligibility certificate, that is essentiality and eligibility. And with all these investigations report, you have to refer them to appropriate authority. And if appropriate authority issues certificate, eligibility as well as essentiality, and then you have to advise them to go to honorable court for that insurance and that parentage and custody of baby affidavit is concerned. And if couple come with all this document, you have to go with program as simple as you go for any ART program. So all these legal proceedings or all these procedures, they are up to couple, not up to practicing doctor.
So I have,
but they will have to run from here to there to avail all those certificates.
So I have one question. I have one patient, real practical difficulty. They have done a procedure of donor oocyte with a husband embryo, which is now in a cryopreserve. And they didn't transfer because the wife had some problem. And they are now asking from 22 after the law to transfer to a surrogate. And all other classes are perfect. But the one condition is they had a donor embryo which was frozen before the law. So how I should go about the transfer now? Because now the legal procedure says there is no donor program for the surrogacy. So then how we go about the donor program?
In this type of situation, you will have to approach Honorable High Court with writ petition seeking permission. And if court is kind enough to give permission, then you can go with surrogacy program.
How long will it take, sir? Because it's a very, almost some thousands and thousands of cases are there.
It will not take much time. High Court is fast as far as any proceeding is concerned. In lower court, JMFC or any sessions court also, it will take time. But in High Court, usually it go fast.
See, I have 3 patients, sir. One, he got married at 56. That's his first marriage. And his wife is 44. And they are now, she's okay for the donor, but he is 56. He said, I got the first marriage. So I said, I cannot give you. So he is now in the court. He has been trying. I didn't know about it. I got married because of so many situations. I have a human right. And he is now in the court more than 7-8 months. And I said, without getting an exemption from the court, I cannot do anything about it.
Exactly. You cannot. Because in Surrogacy Act, it is very clear as far as...
Not the surrogacy, sir. Even I'm asking the donor program. Leave alone the surrogacy, sir. I'm just asking, since you're an expert. Since you are an expert, I'm asking. But nearly 8 months there in the court, sir.
Any age part is very clear in ART Act or in Surrogacy Act. So, if at all any partner, male or female, extend that age limit given, naturally one will have to go for permission from court only. Otherwise, you cannot entertain.
No, it's taking long time, I'm telling, sir. Almost 8 months they're waiting.
Yes.
They were keeping on asking me. I said, I cannot do anything. Such situations happens when it goes to the legal permission. So the legality takes so long a time. But even for a valuable, genuine reasons.
Our experience with High Court is good. In High Court, usually, why these 8 months are gone? Otherwise, within 1 or 2 months, they will give verdict. Favorable or against, that will be a different story. But usually, case comes on board and hearing starts. And once hearing started in High Court, then there is no dates. They will come to conclusion very soon.
But they're very expensive, sir.
Yeah, and will you advise? So, is there a team of our doctors who can represent as a legal team that maybe people who, like Vivek has completed his law, people have to have a team where we can put into it so that they know about the seriousness of the time factor and their...
we have to appear, then we should have a registration from Bar Council. And if we have to go for registration from Bar Council, then registration of Medical Council we will have to waive. Then only we can appear. Otherwise,
that's the problem. So if you go to the other lawyers, it is really 8 months, 9 months there.
But medical legal expert can give a brief how to defend that very case in a respective court, and that advocate will defend that case that way. So that way you can hire services from medical legal expert.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, Patel, sir. That was a very wonderful talk. and you made it very clear, sir. Thank you very much.
Thank you.
Sir. And then we'll move on to the next session, which is a panel discussion on infertility cases. We have our moderators, Ramani ma'am, who is the Vice President of TNFOG. Madam is the Managing Director, Ramakrishna Medical Center, LLP, and Janani Fertility Center. She's won gold medals, 10 gold medals during UG.
Already we are running short of time. You just go ahead.
Okay. Next. Okay. Next, I invite Dr. S. Chitra ma'am.
Yes, I'm here.
Okay.
I'm here. Thank you.
Okay, thank you, ma'am.
Let's get the panelist on the board.
Okay, ma'am.
I can see Dr. Jairani here. I can see Dr. Kundevi here. Of course, all these people don't need any introduction.
Yes,
I could see Madhumita sometime. Okay, Archana Ambujam. She is from. Okay, Madhumita Arun Karthik. I could see her also here. Archana Ambujan is from Tuticorin, and the rest of them are all from Chennai. We have welcome Madhumita. We have the other one, Aruna Ashok. Has she also joined?
Yes, ma'am.
Yes, good. So we have all of them here. Good evening, everybody. Good evening. Welcome the panelists. Shall we move on to the case as we are running short of time, as Dr. Ramani was just saying?
Yes, ma'am.
Straight away into a case. See, I have a 29-year-old medico. She's a doctor. She's 29 years old. She has regular menstrual history with normal BMI, no history of pelvic infection, no medical problems. She was investigated, and then after a year, they came here to see us. She was investigated routinely. Biochemistry, physical examination, everything was normal. She is married to a 32-year-old engineer. He is not a smoker, but he's a social drinker. He does regular exercise, eats healthy. He also has a normal BMI, no medical illness. Couple have been trying for pregnancy for last 6 months. So now we wanted to go ahead and investigate them for infertility. So clinical examination was normal. Now coming to the investigations, when we had the semen analysis done, it was azoospermia. Now from here, how do we handle the couple? Do we reveal this to them? Do we have to wait for some more tests? What do we do? Madhumita?
Yes, ma'am.
With one azoospermia reports, do you want to jump ahead and do all these investigations?
No, ma'am.
Or
Once
you want to wait for a couple more of tests to be coming
ma'am,
around?
once we get an diagnosis of azoospermia and the semen analysis report, we want to confirm it after 6 weeks with another report, because one report is definitely not conclusive. So I would want to repeat the semen analysis after 6 weeks before going for all these other investigations.
So what other investigations? Now Ramani has given a battery of them. Would you go with all these? And what are the best out of these, or what do you want to get out of these? Any one of you?
So I want to add up one more, madam. I want to add up one more thing.
Yes, please.
As you rightly pointed out, with one analysis we cannot say, but we have to educate the patient. Many a times they miss the first sample, first few drops of the collection. That's very important. As senior consultants, we should tell them that the first few drops are important. When they are so much stressed, they cannot get the first sample. So first sample
you have
has
to
the
look at
maximum.
the volume of the sample that they have given you, and if it is very less, then you have to make sure that it's.
Yes, and even the first drop, if they miss, they may miss
the
the whole
volume that is
bulk of
very
the semen
important.
parameters. Yeah, that's very important. We should counsel them and have the important, explain them about the standard of collection, procedure of collection, how they have to give, and also the standard of the laboratory. That is also very important, because they will collect at home and
where it is collected and how it is collected.
Yeah, where, how, what is the time limit?
The container, where it is collected, how it is collected.
Everything has to be very perfectly assessed.
Who has done the semen analysis?
I think past history of recent history of fever, that is very significant. History of drug intake, all those things will definitely alter the seminal parameters. I think, Dr. Jairani, would you like to wait for 6 weeks or would you like to do it much earlier than 6 weeks?
No, ma'am. We can even do after 3 weeks. 3 weeks later, we can do one. Because usually the semen parameters, because the patient will be very anxious. You cannot ask them to wait for so long.
That is why I'm telling 6 weeks, there is no need. I think
so we can ask them to repeat the test after 3 weeks, ruling out the other important things. But within 3 months, we can do 3 tests to make sure that it is perfect or any variations in it. Because we know the semen parameters cannot run in a single line. It has a lot of variations. It can fluctuate. So you must be assuring them that the semen, as spermatogenesis has 72 days. So we have to wait 3 months to see entire the film around 3-4 collections. If you are very sure after 3-4 collection with the pellet examination also being done, then only you have to certify them as azoospermia.
If there is no sperm, then you can make sure that it is
then only we can certify them as an azoospermia.
No two semen analysis would be alike. So you have to wait and watch. You have to compare the previous one and the present one. And how about these tests?
So you have confirmed that it is only azoospermia. And even the pellet shows absence of sperms. If there is sperms present in the pellet, then we call it as cryptospermia. Okay. So it's proved that it is a case of azoospermia. Then what are the other investigations? Anyone likes to share?
We have to do this FSH and the total testosterone, and if we've got a sexual dysfunction, probably a thyroid and a prolactin. And this will tell us whether it is going to be an obstructive or a non-obstructive causes. So depending on the obstructive and the non-obstructive, if it's a non-obstructive, then probably you do a genetic testing.
Ma'am, basically, I will do first a proper clinical examination. That's very important. We have to see the height of the patient, any other clinical abnormalities for any other variations in there. There can be a Klinefelter's, or he can be a hypogonadotrophic with an obesity with a BMI very high. And he can have a gynecomastia. We have to see the volume of the testis. We have to assess the volume. We have to assess the hernia or any other cryptorchidism feeling, or history or examination of the scrotal scalp. Everything has to be very perfect. Then only we can plan for a basal. Because many of the time the clinical examination itself will give us a lot of information about what are the tests that are needed absolutely for this patient of azoospermia. And very many times we can clinically diagnose if he has a mush, if you don't have a beard, if you are clean shaved, have a feminine features with a gynecomastia, obesity. We can be very clear that he may be having a low testosterone and we may have a gonadal failure. So these are all very commonly we can encounter in a patient. So perfect clinical examination and genital examination and history taking gives 50 to 60% of the diagnosis of the azoospermia, the cause and the etiology. That's very important. Then we can go for all the other parameters.
Again, retrograde ejaculation also has to be thought about. Retrograde ejaculation is another important one.
I mean, as a retrograde, probably the volume, right? As Dr. Chitra was talking, when you have a less volume, then probably think about the retrograde. And I assume that you said it's a bilateral absence of vas, is it, for this patient?
Yes.
And we have to look for the kidneys as well, because it is always associated with the renal anomalies.
Yeah, agreed.
Like Mullerian anomalies, this also you have to look at. Okay. How do you differentiate these two? Obstructive and non-obstructive azoospermia.
Ma'am,
does it really matter?
Can I answer?
Yes.
So from the clinical examination, if the ovarian volume is normal, sorry, the testicular volume, the testicular volume is normal, and if he has all the other features of the testosterone level, we always feel that it could be a obstructive, can be a reason for the obstructive. Because if it is a non-obstructive, it could be because of any hormonal or the hypogonadotropic or a primary gonadal failure. All will have an additional hormonal parameters in it. So with a clinical examination, you can have an idea of could be a reason for an obstructive or non-obstructive. And also history of STI, any other treatment for tuberculosis, all these things, and also any surgery in the inguinal canal, any other hernial surgery, all these things can have a thinking of an obstructive azoospermia. And non-obstructive azoospermia, we can have a clinical, clinical features also suggestive, and all your biochemical parameters will be normal if it is a non-obstructive azoospermia. Her FSH LH will be normal, her testosterone will be normal, and all the volume measurements, everything will be normal. All his sexual functions will be normal, except that his semen parameters alone will be, azoospermia in an obstructive. Whereas in a
like Kundavi has already mentioned that if you want to do a single test, it is only the FSH.
Ma'am, even that, there are a lot of controversies regarding the levels of FSH. When they talk about 7.5 as a cutoff, even when you have an FSH of 10, you're still able to get
That has even gone up to 25. Even with 25 FSH, they are able to get sperm retrieval with micro-TC. That is different. Okay, but still basically grossly to differentiate between obstructive and non-obstructive. So
now even people talk about 17 OHP when compared with an FSH and the total testosterone. 17 OHP will give you the intratesticular response. So people talk about 17 OHPs nowadays than an FSH and total testosterone.
The 17 OHP gives this idea about whether we have to give HCG injections to improve the sperm count for the patient or not. If 17 OHP is less than 0.5, then use of these HCG to increase the intratesticular testosterone is useful. If the 17 OHP is already high, then no need to give supplement.
For HCG will not work.
So the FSH in this particular patient was 50 milliunits. Okay, scrotal ultrasound and Dopplers were normal. So this is the hormonal levels in azoospermia in various situations, like elevated FSH and LH is normal with or low testosterone is a primary testicular failure. Low FSH, LH and everything, if it is low, it is hypo, which can be treated very easily. And then normal FSH and LH with testosterone, normally the interpretation is either it could be normal or it could even be primary testicular failure. So how would you proceed with this case? The patient is a young couple. They are not interested in having a third-party reproduction. They want their own gametes. What are the options available?
Ma'am, the recent studies by Ramaswamy et al., what they say is even with a non-obstructive way, you have like 10 filters, the FSH is at high levels, but you can still give them a medical management of either a letrozole or anastrozole for about 8 to 12 weeks, and then try a micro-teaser where you would definitely get few sperms.
Yeah, that thing has come out. And it gives some sort of antioxidants plus letrozole or even clomiphene can be given. So whatever it is given, it will improve slightly the incidence of sperm retrieval with micro-TC. That is what they have come to a conclusion. Okay.
In this case, I think before we go ahead with the micro-TC, I think we need to counsel the couple, find out what they want actually. Whether they would like to have it on the day of their collection or they would like to have a diagnostic micro-TC and then proceed. If the couple says they would like to have a diagnostic micro-TC, and then probably go ahead with that, because otherwise you have to go ahead twice for the procedures to identify the sperms. If you don't get sperms following a micro-TC, what do we do with the eggs? Again, has to be counseled with the couple.
Okay. See, then one more thing is, before planning for micro-TC, is there any way to counsel the patient that this is your, do you want to go for a genetic testing?
Yes, ma'am. If it is a non-obstructive,
that is very, very essential. Non-obstructive azoospermia, genetic
all of them require.
Yeah. So what is the genetic testing would you like to do in this patients?
Karyotyping,
Y chromosome deletion.
Y chromosome microdeletion. Even if there is a bilateral congenital absence of VAS, then
CFTR gene
also will be valuable for this patient.
In that case, I would do it for the women rather than for a male person, because 50% will be of things. So in such cases, a female also would be beneficial.
To be interesting, ma'am. Today I saw just 1 hour back, I saw one patient. He has a karyotyping of 47XXY, and he had one history of a natural pregnancy. They are married 12 years. He got pregnant on the 2nd year, and the baby had an anomaly that was terminated. But after that, they evaluated him to be an azoospermia, and then they noted that he has a chromosomal aberrations too. But he had a natural pregnancy. You cannot believe it. So They came after 10 years because presuming that they had an actual pregnancy. So these are all things can happen even with the karyotyping being an abnormal of a client filters. Still, he had a natural.
That's what we should always think at the most, we need only one sperm. And so many millions are available for one conception. So we have to bank on that one good sperm. So we have to work again and again for that best sperm. Yes.
Archana?
In filters, yes, still there are chances that you can retrieve. Yes. Archana, anything you have to say?
Yes, ma'am. Yes, ma'am.
Yeah. See, you have been quite so long. I think you can join the discussion. So
Yes,
what is, apart from the Klinefelter XYY syndrome or whatever it is, then Y chromosome microdeletion is one of the important abnormalities that will lead to azoospermia. So is there anything significant association between the Y chromosome microdeletion and sperm retrieval rate in micro-TC? See, we have the azoospermic factor, no? There is A, B, and C. If the patient, if you do a analysis of Y chromosome microdeletion, it is going to be azoospermia factor A and B, then definitely we can say that there is no chance of getting sperms even in micro-TC. Only patients with the azoospermic factor C, you can expect 50 to 60% of sperm retrieval rate in these patients. But again, we have to counsel the patient that the chances of transmitting this microdeletion of Y chromosome to the offspring, male offspring, is there. So that has to be discussed. Then only we can go for it. Probably if it is going to be a female fetus, then nothing is going to happen. The couple are going to have a healthy female child. Okay. So what are the sperm retrieval techniques in obstructive type of azoospermia and non-obstructive?
Basically, in obstructive, we can go for PSAM epidermal sperm aspiration. If we don't get, then we go for a testicular sperm aspiration.
Okay.
Basically, most of the patients, in case of obstructive patients where the obstruction is at the level of vas, we are
epidermis is loaded.
Yes, ma'am. So it is loaded. So generally, when as soon as we put the needle, even in just with the PISA, we get the sperms.
Okay, Kundavi, are you happy with the PISA sample or you want to go for testicular sperm aspirate?
I think I'll be happy with the PISA because you get good motile sperms.
That's right.
As like any other normal sperms, yeah.
Then
maturation will be good with that.
Maturation will be good, but again, even testicular sperms are not bad. Yeah. Because some people, they say that ROS activity is very low.
ROS will be less with the testicular sperm. Yeah.
So they say the fertility and the outcome may be better with the testicular sperm aspirate. Okay. Then in the non-obstructive type of azoospermia, what are the methods where you can get the sperm retrieval?
Testicular, or it is a plain testicular mapping, which we can do it with a whichever side of the testis is having a better volume, we can start with that side and then do testicular mapping. But TC,
micro-TISA is the best.
Micro-TISA is the gold standard, but before that we can try a testicular mapping. If it is not possible, then micro-TISA we have to do, and then only micro-TC, and then we have to get the sperms.
If you don't have a micro-TISA, probably a multiple biopsies would be a better biopsy.
Because all people may not be having a micro-TC, facilities for micro-TC, and you need to have a state-of-art ART center to for a ICSI to be done. So maybe, as Dr. Kundavi suggested, testicular sperm, that is my TC, can be done at multiple sites.
Multiple.
So this mapping means that you have to pick up from different sites.
Right.
And accumulate everything together.
So when you come to the obstructive azoospermia, this PISA with rescue TISA or PISA alone, they have compared, and they found out that the successive retrieval are much higher in PISA with rescue TISA. And about congenital bilateral absence of vas difference, there can be 100% sperm retrieval, and post vasectomy it can be almost 97%, and post infection also it can be 97%. And the common causes for obstruction due to infection were the common infections causing azoospermia.
STI.
STI is the commonest. Tuberculosis.
Gonorrhea
and tuberculosis also.
Tuberculosis is the next year.
Think about. Then in the non-obstructive, what will be the success rates? If you are going to do a TISA or a TSA or a microsurgical TSA, which one will yield the highest one? And
TISA will be. TSA will be the best one.
Micro
TSA
will be
testicular
the
aspiration
one.
will be the best one, ma'am.
But as we have discussed earlier, everybody may not have the facility to do that micro TSA. And this is the result of obstructive versus non-obstructive, and the outcome using ICSI. Of course, we have to go only for ICSI. And the sperm retrieval rates are very good with obstructive one. And again, 2PN fertilization rate, top quality embryos and live birth rates, everything is good only with the obstructive and compared to the non-obstructive one. So Chitra, you proceed. I think.
Okay. They decided to go for micro TSA. Sperms were obtained, and we got about 8 embryos. They didn't do the embryo transfer because patient had multiple follicles in that cycle. So we were worried about the OHSs, and so did not have a transfer that cycle. So FET was planned later, and 2 subsequent cycles he could not prepare the endometrium well, and so transfer was deferred. Now, if no success, what may be the reason? Then if you had a good endometrium and still the embryo were transferred, and still if they did not have a good, did not have a good pregnancy, what could be the reason for that? And do we like to repeat micro TSA? And what should we do, or how do you address the endometrial problem?
If I'm allowed to discuss and counsel this couple, and if they want to repeat another cycle of IVF when we know the good endometrium and other things, probably I think the law also allows like 50-50. You go with the husband's sperms, another 50 with the donor sperms. And depending on the things, you don't mix the embryos, probably do it with separate transfers if the couple agrees for it.
One embryo transfer, we should not use both.
Yeah, and we need to assess the other reasons for recurrent implantation failure also. We should not think only it is the embryo that is at the reason. We have to think about the endometrium, and you go assessing the female partner also. Whether she has any other reason.
In case we have not done a hysteroscopy, probably we would suggest to do a hysteroscopy to find out if there's any, or a 3D and ultrasound for a cavity.
But I think in these cases, hysteroscopy may be of much use. Then, any other thing would you like to do apart from your
genetic testing of the embryos will be of use because of the male factor is really problematic.
That's what.
So pre-genetic testing of the embryo, and then uterine side, if the uterine endometrium is very thin, repeatedly hysteroscopy definitely, and also look at endometritis CD138 and see whether there is endometritis which is underlying there. And then uterine factors, multiple maybe adjuvants to improve the endometrium. It can be a PRP or vaginal sildenafil. So improving the endometrium, getting at least 7 to 8 millimeters, and transferring a euploid embryo will be of a good choice for the patient.
But here they've written adequate preparation of the endometrium.
Nowadays, PGT, according to the law by the PGT, we are not supposed for the repeated IVF failure. There is no indication for PGT nowadays by the ART law. I think senior IVF specialist here will agree with me. You're not supposed to do a PGT just for your recurrent failure. That's what is given. It's not
when the sperms are from the retrieved sperms from the testis, can we do it to find out about the embryo?
There is a clause telling that if there is a reason for indication for genetic testing, we can still do. That's what when we discussed in the medical legal forum also they had told, madam, because the patient has had IVF failure and there is a azoospermia and we have retrieved sperms where the aneuploidy rate is more. So terminal age more than 38 and there is a previous 2 failures or sperms of azoospermia couple or a previous child anomalous.
We have to check.
I think we
have to check. Arna. I think there was not included in that. We have to see for the indication for the PGT. We have to check. No, I'm not sure, but maybe you're right, or I think it was not correct for just because of the implantation failure. You are not supposed to do a PGT. That's not indicated by law. I remembered looking into it.
Okay, we will
confirm it. Just for because when we are telling, we have to tell the proper facts. No, why we are doing to that.
But again,
endometrium, what's the battery of investigation that we would go about? Thin endometrium.
Thin endometrium. Okay.
Yeah, whatever Everything
That's
said.
Aruna's specialty, thin endometrium.
Aruna's specialty. Okay.
Another question is, if by
1, 2,
doing
3, 4. Rattle, Aruna.
Yeah.
1, 2, 3, 4.
She has given already. She has given all the list. Very fastly, she has given the list of thin
CD
endometrium.
128. I was fixed with
CD
it, so I just
138.
wanted to hear it once again.
Yeah. Madam, thin endometrium, we wanted to
Anna,
look
am I
at
right?
the chapter. Yeah, thank you, madam. So CD 138 will tell us whether there is a plasma cells is more or not. If it is more than 5%, then we are indicated to treat them with at least doxycycline for 21 days. And then after doxycycline, you have to give probiotic and then take her for a HRT preparation. In HRT preparation, the drugs that can be used is, I think from Kundavi madam, we learned tamoxifen. We have tried tamoxifen for so many couples and got good results. So tamoxifen helps for improving the endometrium in tablets. Evion vitamin E helps, and the sildenafil, vaginal sildenafil, and also ester gel. Estrogen, because proguanova causes lots of estrogen tablets causes lots of acidity. So patients complain when you high up the dose. So vaginal or gel will be useful. And also PRP, if it is prepared, the count has to be checked after PRP, and it is a fresh PRP, has a higher success than a frozen one. So fresh PRP, we can try it. Even with PRP, if the endometrium is 5, 6 and is a Asherman's which is treated and the patient is very poor, it is like sending the patient for surrogates, then we can think about hysteroscope, subendometrial stem cells, in which it can be 2 types. One is you can give GCSF, collect from the peripheral blood and inject in the subendometrium. Or otherwise, it is even more worse. Then you can go for a bone marrow, aspirate, and then do it subendometrial. And now we are also, after the Asherman's, there is a stent which is available. Also beautiful it is. So after Asherman's, we can put a small 5 ml inflatable stent, which is produced by, I think, one company. And we are putting it inside the uterus for 5-6 days. Then the re-additions occurring, formation is reduced. After stem cells, waiting for 1 month and then preparing the endometrium works out very well. The third thing, for instead of stem cells, if the patient is very much not willing for bone marrow or anything, then we can use mesenchymal stem cells, which is allowed as a I think there is a person in Bombay who is preparing it and giving. It's like live cell. They are having mesenchymal prepared from the umbilical cord stem cells. So these mesenchymal stem cells also have very good value. So I think with this, we have to improve the endometrium up to at least 6 or 7 and then place the embryo.
I mean, sometimes even a 6 millimeter endometrium might get, the embryo might get implanted. That is individual. Kundavi, can you explain your...
instead of doing an HRT cycle, sometimes you can bring them in a natural cycle.
Yeah.
That will really give you a good endometrium. Tamoxifen, we give them 20 milligram BD for 5 days.
5 days, from day 2 to 5.
5 days. And then earlier we had this HCG which came in 200 international units. That was also we were trying. As of now, I think that is not available. So I've stopped using the HCG
intrauterine. Yeah. That we can always create by diluting. That's a different issue. Okay. So ultimately, this is what we needed to discuss in this case. So the clinical management of non-obstructive azoospermia, first confirm that azoospermia is due to spermatogenic failure. Determine who are the candidates for sperm retrieval based on this azoospermic factor A, B, and C, and identify who will benefit from interventions prior to testicular retrieval. That is by giving antioxidants and some form of hormones we can try. And in patients with varicocele, that's a different one. Okay. Select the best surgical method for testicular sperm acquisition and then utilize a state-of-art laboratory technique to handle surgically extracted testicular spermatozoa. Then a question to Aruna. See, by doing PGT, are you always sure that the embryo is euploid? Because sometimes what happens is it is a mosaic embryo. What the biopsy we take at that particular site may be normal. But there are always chances for autocorrection also in this mosaic pattern. So it's basically, I think it is the luck of the patient and the luck of the consultant.
Definitely, madam.
And you can't give guarantee by putting euploid embryo, it's going to implant.
Even after euploid pregnancy, you have to monitor your first trimester staining. You have to see your nuclear transfers. Everything has to be done. Even if you transfer a euploid and you get a pregnancy, you have to check their first trimester staining, which is also very important.
Sometimes after euploid, they get a miscarriage and then with the embryo transfer they have. But to improve the success rate, these things can be offered. But mosaic, up to 50% of mosaicism we are transferred, and they have in 12 weeks NIPT and amniocentesis is becoming normal, madam.
Okay.
So mosaic.
The recommendation is you can still go ahead and transfer the mosaic.
We can transfer. If there are no options, we can transfer mosaic also.
No, there go. So then what is the big fun in having a
Exactly, ma'am. What is the point of doing such?
So much, give the trial nature itself to correct it and give it. That's how we always do.
Very few centers have given results for PGT.
Yeah.
Probably one center.
Then, so this is what the key point is. Micro TC is an option. Counseling is a must. Okay, so I think all these things we have discussed. Okay, now let us move on to the case 2. 39-year-old Mrs. P was referred to us for fertility management. She complains of severe dysmenorrhea and dyspareunia. Her cycles were normal. Married for 5 years and investigated earlier. She was diagnosed to have bilateral chocolate cyst. She was started on medical management. Male factor was normal. Okay, so you comment on this because she is 39-year-old. Fertility treatment. Are we just
no medical management, ma'am?
No medical
management.
This is the point I wanted to bring about in this particular side. So when the patient, but on the other hand, what treatment would you like to give to this particular patient?
This depends upon her size of the chocolate cyst, madam. We have to assess
size of the chocolate cyst matters.
No, we have to check her AMH level. Already she's
ovarian reserve.
Reserve will be on the lower level. One. And second thing, she is very symptomatic. So even if she has whatever the size, she's now symptomatic. Must have had a lot of pelvic adhesions, and because of that, lot of anatomical distortion. And definitely, she's a case of for a ART. And this ART we have to plan depending on the, every factors. Rather, you cannot.
She is very symptomatic, severe dysmenorrhea and dyspareunia.
So definitely,
so that is an indication. That is an indication for surgery. See, leave alone ART. See, probably she is an ideal candidate for ART. So look at her ovarian reserve. Then you advise her regarding, like you can go for oocyte picker, freeze. Then surgery. You can go for surgery followed by transfer. Whatever thing can be done for her. So this patient.
I would say that because she's symptomatic and then bilateral endometriotic cyst, probably surgery first. If her AMH is normal, then because if you have a huge endometriotic cyst and you don't have any ovarian antral follicle count, then even to get eggs from that will be difficult. Probably in the best hands, do a proper cystectomy, then take her for IVF.
Archana, what is your take home in this particular case? Would you want to go for a straight ART or would you want to go for surgery followed by ART?
As Kundavi madam said, it'll be it depends on the size of the cyst. If the cysts are very big, then aspiration is difficult. There's increased incidence of abscess formation, everything post-retrieval. So if she's very symptomatic, I'd prefer to go for a surgery.
Okay, so that is what
I would want to go in for oocyte retrieval, freeze the embryos in case and then go in for surgery, because like at 39 she will already have very low ovarian reserve. At 39 we expect, and when suppose in case even if cystectomy we do, what if we compromise the ovarian reserve further? So suppose in case if we are able to do the oocyte retrieval safely, and if the cysts don't hamper the oocyte retrieval, go in for a oocyte retrieval, freeze the embryos, and then do the surgery and then go for a transfer.
Two schools of thought. See, she had bulky uterus, posterior adenomyosis, endometrium was very thick, 16 millimeter, could be a polyp, bilateral ovarian mass that is suggestive of endometrioma, and the size of the ovarian chocolate cysts were 5x6 and left ovary it was 5x4.
Madam, the ESHRE guideline says if the size of the endometrioma is more than 3,
yes,
and if there is a thickness also is very high, 16 mm. So she is an ideal case. She needs hysteroscopic evaluation. She needs a laparoscopic evaluation to correct all those things. Then only whatever you're going to do will be of use. We can check her AMH. We can check her AMH and then plan a proper surgery and then proceed for the IVF, ma'am.
So this was the polyp. You can see and see the adenomyotic uterus and again bilateral chocolate cysts. Obviously, she was coming and begging for laparoscopic surgery. So I think all these things we have discussed, and we have discussed about the AMH also. Okay. So what are the precautions also? I think Kundavi has said it should be done by a person who is expert in this endometriotic surgery. And suppose you can face many complications even during surgery. because it could be associated with a deep infiltrative endometriosis, especially a bilateral ovarian thing. So probably we might need a team of colorectal and urology surgeons with us during this surgery. Then how to prevent additions, proper hemostasis, and then addition preventing barriers. So these are all.
I would do an ultrasound kidneys as well, because you see a lot of pressure changes in the kidneys. Look for urethral involvement as well.
Ultrasound of whenever you do an ultrasound for a endometriotic patient, never fail to see the kidneys, because that is deep infiltrative endometriosis, you may not have anything in ultrasound, but silently it can kill the kidney, and the first presenting feature may be the renal failure. So we have to be very careful about it. Like Jairani had already mentioned, these are all some of the recommendations by yesterday, which says any endometrioma larger than 3 centimeters could be done. But again, the clinician should only consider cystectomy. It is not that always you need to do a cystectomy when the ovarian endometrioma is larger than 3 centimeters. So the main indications are, one is pain. Second is when you are not able to access the follicles. And when you suspect malignancy, we have to go for surgery. So anybody can, Chitra, where are you?
Chitra is there.
Okay. Chitra?
Yes, I'm here.
Yeah. You just go ahead with the endometriosis fertility.
That's right. There's something called as endometriosis fertility index. Anybody to talk to us about that? How do you score it and how do you rate it? And do you do this for every case that you operate on?
3 parameters, ma'am. We use the age and the duration of the infertility, and I think these are the 2 things that we calculate, and also any other past obstetric history. These 3 factors we look into it and make a score. And then, of course, with the surgical factor, there are 2 factors. That's what a history, your history and the surgery. With that, we calculate a score, which we plot in that gives us the scoring. If the score is good, you have a better outcome. That's what.
If it is.
This shows the probability of pregnancy rates actually, and the least functional score has to be taken. The most the score, I think we have a better pregnancy rate.
So this is the hysteroscopy.
It's better to have this always printed on your case sheet, or you have a paper and attach it whenever you have an endometriosis case, so that we'll be able to counsel patients better. That's what we get out of this.
So this is the same patient, laparoscopy was done, and you look at the endometriosis for EFI scoring, it is only 3. So based upon the estimated pregnancy rate, so if the EFI score is less than 3, you have to plan straight away for ART. Okay. Then if it is 4 and 5, maybe you can have 1 or 2 cycles of trying for ovulation induction and IUI. And if not, you can go for
after 7 they say it's good.
ART. So if it is higher, beyond anything beyond 7, her chances of spontaneous conception at the end of
pregnancy rates with endometriosis is good. Then
so this particular patient, because her AMH was also less than 1 and her EFI score was less than 3, she had necessarily undergo ART, and we could have only 4 eggs retrieved and only 2 embryos were reasonably good, because the male factor also was showing some oat. Okay. Now, what is the precaution would you like to take before you transfer it? You want to go for a fresh transfer, or if you want to go for an FET in this particular patient? Mind that she has adenomyosis also.
Though people talk about medical management.
You have to go for down regulation. How do you down regulate the patient?
Ultra long protocol where you at least give about 2 doses of analogs. But I think the latest recommendation do not support the ultra long protocol for these women.
No, if the adenoma.
But before FET, we can go for it.
Now, with the endometriosis, it is always better to go for an FET, because sometimes if she has a cyst and you are doing an oocyte pickup and then plan the surgery and then go for the transfer, there is a better outcome. If she has an additional added adenomyosis, you have to think of your GnRH agonist, give her 2 or 3 shots of GnRH agonist, reduce the size of the adenoma, and then you plan for the transfer. That gives a better pregnancy outcome. Yes. So that is the role of medical treatment for an FET. in endometriosis. No other way for fertility medical treatment is indicated except only for these conditions.
Like how Kundavi
uterine volume, does it matter, Ramni?
Suggested
Volume
one
of the
or two shots
uterus.
is sufficient prior to FT. But if you want to reduce the volume of the uterus, I think minimum 3 months of TNRH.
Months of suppression,
suppose if it is going to be a 3 into 4 size centimeter size adenomyoma, quite large one, where the cavity is large. See, even after 3 doses, it may not come down. Then what else you
Letrozole can be added.
Letrozole can be added.
That's what.
So there are evidence.
Ramni always favorably keeps calling this very often, her call always in the clinic. She keeps saying about reducing the volume of the uterus before we do the transfer. So she always adds letrozole with this GnRH. That's what I was trying to get her on to.
See, so the protocols in adenomyosis and endometriosis, I think either protocol, agonist or antagonist protocol is usually good. And then you have to go for a 2-stage ART. All these things we have discussed. Pick up, freeze the embryos.
Only thing is, if you have a question mark endometrium, ma'am, the cavity, then your transfers become difficult because your catheter may not reach the fundus. So we have seen that it just stops at middle of the cavity. So you need to have a long-sized
transfer is essential. Mock transfer is essential. We have to mark the length of the catheter and the direction, everything that is essential. And again, hysteroscopy is very much needed in all these women, especially with adenomyosis. Because with the associated adenomyosis, what happens is sometimes you can see the crypts of this adenomyotic gland openings, which can be created out so that it will be better. It will have a better implantation rate. And again, we would have met, all of us would have met with internal loss, tightening or stenosis in these patients with the adeno. So that has to be cleared up. So this is again a study which says that GnRH agonist plus HRT gives better FET results. Then there was one more study which says a combination of letrozole with GnRH can improve the implantation rate. Then, as I said, it is mock embryo transfer. I think. Then would you like to go for a single? Pardon?
You give letrozole alternate days or daily for 3 months?
Daily I give 2.5 milligram or 5 milligram depending upon the BMI of the patients. I give them GnRH. My preferred drug of choice in these women are only goserelin. That has got a better outcome than leuprolide. Not for these sort of larger adenomyomas, plus backup with norethisterone. Or sometimes I do give Dynegist also because the mode of action of all these things are at varying points, not the same. And we have got very good results even with recurrent implantation failure with adenomyosis. And again, a single embryo transfer.
Kundavi, you were saying something. Just a minute, Ramni. Kundavi was saying something about placing the embryos in a difficult cavity.
Yeah, that is what she was telling. A question mark sign and the length of the cavity that is larger, we can have some problem with the transfer. So that is why you need to have a mock embryo and reduce the volume of the adenomyosis prior to transfer. That is essential.
Maybe such patients, if you have a difficult transfer, the surgery also would help them if you release all the additions and other things.
Yeah, failed IVF is an indication for surgical management of adenomyoma. Then single embryo or double embryo?
Single embryo transfer.
Yeah, because the complications.
I think the complications are more because you have high risk for preterms. And twins with an endometriosis, with an adenomyosis, frozen pelvis is going to be a difficult option.
Okay. Then anybody has tried with atosibon because you
we regularly give atosibon for women with endometriosis for fibroids and adenomyosis, ma'am. I think we have even published a paper on that and we've got good results using an atosibon.
How do you do?
Kundavi, explain. How do you use it?
How do you do?
You have that the 37.5 of the, it is very expensive, so we use only the smallest dose. We give a test dose and then the 37.5 has been given after the transfer, ma'am. We take a consent.
And you don't give it before the transfer, no? Before transfer.
Before transfer.
A test dose, yes. During the transfer, it's been slowly given.
Okay.
After the transfer.
We are not giving the full dose like preterm, only the loading dose of 37.
Only the loading dose has been given because the full dose has been expensive. So only the loading dose has been given.
Loading dose, you give it just prior to transfer.
Transfer, yes, but we give a test dose, we wait for some time and then just before the transfer, we give the atosibon.
Okay.
That means it's 6.75.
So it is for general you are telling or for the adenomyosis, madam?
She's telling for endo and adeno.
Endoadenomyosis and the fibroids where you see endometrial waves, such patients we give them an
patients, yeah.
Okay. Okay. So
and
then
previous
one
history
more
of
thing.
ectopic pregnancies also we give them.
Okay. Then one more thing, most important thing for the implantation in adenomyosis is the thickness of the junctional zone. See, when generally we say in adenomyosis, the junctional zone is more than 12 millimeter. But they have found out by studies when there is a lot of implantation failure, when the junctional zone is more than 10 also. So the outcome implantation is good when you bring it to around 8 or less than 8. So this can be very easily achieved by giving GNRH analog. So how do you measure the junctional zone? 3D ultrasound or in or MRI will be the ideal one, but we have to weigh the cost benefit of it. Okay, so these are some of the important things I wanted to tell you. Then IVF results may not be significantly different when you use ANTAG or agonistic protocol. And Kundavi had already mentioned, suppose if the patient has undergone adenomyomectomy, 2 times failed, she has undergone adenomyomectomy. What is her, when she can plan the pregnancy, whether it can be spontaneous or if it is going to be an ART cycle, when do you want to transfer the embryos?
After 12 weeks.
After 12, minimum of 12 weeks. Here also they suggest, again, we can give 1 or 2 shots of GNRS, then you can go for transfer.
I think once the surgery is being done, in case the patients go to some other gynecologist, we have to make sure that we give them proper notes saying that, yes, this patient had adenomyosis or the cavity is open and then she has to go for an elective cesarean because the risk of rupture is very high.
See, look at the rupture, it is 1:8. And these are all the obstetric complications. First thing is you can have miscarriage at any site, any term, preterm delivery, and placental malposition. That is very, very high. Low-lying placenta. It is because of the myometrial contraction. Okay, adenomyotic thing, that contractions can lead to abnormal placentation. And there is shallow placentation which can lead to preeclampsia and small for gestational age. So these are all the obstetrical complications, and better a patient, adenomyosis patient, you can always plan delivery at 34 if she had already undergone adenomyomectomy, or you can go up to 36 to 37 weeks when she is being managed medically. So this
and
is
even to do a transfer, ma'am, it probably an half-filled bladder or something because the cervix will be literally pulled up to do
very
that.
drawn up, very much drawn up. It's no need any bladder at all.
And the length
and
of
very
the cavity.
importantly, ma'am, this localization of the adenomyosis prior to your transfer and after the pregnancy, you have to be clear because the placenta, if there is a placentation which is happening over the adenomyosis, there is a high risk of complications of all the abruption and preterm labor, IUGR, sudden intrauterine death, everything is more common. So if you localize the placenta posted exactly over the adenoma, there is a risk of all these complications you have to keep in mind. They have a risk of pregnancy complications more with this type of a placentation exactly occurring because the latest ASRM guidelines, ASRM latest update says about this, ma'am, in a very beautiful way. They have conducted a study and compared.
That's
that
a very nice
says.
information, Jairani. So this is again a general algorithm. See, it is not that all patients with adeno or endo can need fertility treatment. We do come across spontaneous conception in endo patients. They become pregnant and we see large endometrioma. Recently, last month, I did a patient who had a very large endometrioma around 15 centimeters size. Only thing is we need to have a proper follow-up. And based upon the symptoms and then associated male or tubal factor, I think the patient will need a ART. So I think almost all the points we have discussed. And I think we can stop with this because already we have exceeded the time. And anyway, it was a nice experience having a chat with all the learned panelists. And I hope we would have given some important salient points to be discussed. Thanks for the opportunity given. Thank you, Dr. Sampath and TNFOG for giving this opportunity.
I do thank along with Ramani for the opportunity, Dr. Sampath. And I thank the panelists for being with us patiently this long and giving a lot of inputs as well. Thank you.
Dr. Ramani Devi?
Sir,
yes, sir.
Yes.
How are you, sir?
Yes, fine. as far as discussion of PGT was there, I didn't want to disturb you. But as per ART Act, if it is pre-existing, heritable or genetic disease,
only that should be done.
in
Yeah.
any partner,
It's not for implantation, we should not do that.
then only it is compulsory.
Yeah.
Otherwise, it is not routine that in each and every case before implantation, we should go for PGT. So
Go for
PGT.
PGT is not been recommended.
Not recommendation, ma'am. It's in the ART law. It's not only for previous history of any familial disease, any genetical disease, any other loss, any downs, everything only we have to do. Otherwise, it's not indicated as a routine. For recurrent failures, it should not be done, ma'am. That's what it's given.
In either of the partners or in sibling family, then only.
It should not be done. It's not indicated. That's what is given. We have to clarify it, Arna. That's why.
Sir, we have an expert in with us today. I think he has made a clear-cut thing. It should not be. Okay.
That's why I told you. I correct. That's why I was
should
telling
not be routine. Yes.
Thank you, sir. Thank you for your input.
Yeah. Thank you.
Thank you, madam. Thank you for making us do some thinking. And it's really lovely to talk with all. Sharing your expertise, experience, everything is really wonderful.
I think I received a lot of inputs from Jairani, Aruna, then Kundavi, Madhumita, and Archana. I think it was a very nice chat, I should say, today.
Yes.
Thank you, madam.
Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you so much.
Thank you, ma'am. Actually, it's a very interesting session for all of us. And if we have more time, we could have discussed more cases. Ramani, ma'am, thank you so much for bringing up nice, interesting cases. It is useful for all general gynecologists like us. And I thank Revati, ma'am, Sampath, ma'am, and Dr. Vijayalakshmi Gnanasegaran, ma'am, who are the organizers. I thank the chief guest, Dr. Asha Bakshi ma'am, and Dr. Vijay ma'am and Nidhi ma'am who have agreed for to be the judges for the UA session. The speakers, also thank the speakers. Both of them did an excellent job. I thank Professor Patel sir and Vivek Madi sir for the very interesting talk on Surrogacy Act, and panel discussion was wonderful. Thank you, Ramani ma'am, Chitra ma'am, Jairani ma'am, Kundavi ma'am, Archana, Dr. Archana and Dr. Madhumita, Dr. Aruna. Thank you so much, and thank you all the delegates who attended this program. And thank you, Sahiti and Mrs. Priya, who have made this program a successful one. Thank you. Can
we have a picture with all of us opening the
Radhika,
video? Sir.
Radhika.
Yes, ma'am.
Mention the UA speaker's name, Dr. Nivedita and Dr. Jayashree.
Nivedita, yes, ma'am. Thank you, Dr. Nivedita and Dr.
Jayashree.
Jayashree Nataraj. Suma madam's daughter. She is Dr. Suma's daughter.
Anyway, thank you, Radhika.
Yes, ma'am. Thank you, ma'am.
Thank you to all.
I think take a picture with us, sir. MC sir, you can also join us in the picture. Patil sir.
Sahiti edikriya? Patel
Yes,
sir.
ma'am. Yes, ma'am. I'm taking, ma'am.
Or photo.
Patel sir, video illa.
Taken, ma'am.
Thank you.
Thank you, Sahiti. Thank you all. Jairani.